Hello, Brain News. I see your hand raised. I'm trying to get you in. Can you hear me? Can anybody hear me?
Professor Barbara, do you hear me? Yeah, Professor Barbara is here. Okay, the practical part of the second day is over, and I hope you enjoyed everything that was brought in this practical and theoretical knowledge. So now it's time to the theoretical part of our second day. And our first speaker will be Louise Borja, professor from Brazil, with this topic, how-based neurosurgery. Yes, can you hear me? You hear me, professor?
Yeah, I can hear you. Morning. Hello, Yuri. Hello, how are you? Good to see you. Are you okay today? Yeah, it's okay. I just saw the picture in the chat. You? I just read too much yesterday or? Too much. Thank you very much for the contribution. I really who will be back? Who will be back?
The sound is bad. There is no sound. Zaila, can you speak? We start in about 33 minutes. We haven't started yet, Zyla. Okay, we start in 24 minutes. And welcome, everybody. Welcome, Harshad. I don't know if you're there, Harshad. Oh, Muhammad, help me. Looks like Muhammad Helmi. Hello, Muhammad, is that you there?
Yes, hi John, how are you?
How you doing?
All good.
Let me, is your camera okay?
Yes, I'm just
Getting ready? Okay, I just want to check.
giving the settings.
Because we can't have a host without a camera.
Of course. That will be a ghost, not a host.
Yeah. Okay. Okay, we're all set there. I got the right banner. Well, we ought to make you a member of Neurosurgical TV.
Sorry, John?
We ought to make you a member of the team of Neurosurgical TV.
That's an honor for me.
Well, okay. Well, all you need to do is see that banner I got and I was thinking about that, rather than when we start the show, I won't say this is John Bennett. You would say I'm Muhammad Helmi. From part of the team of Neurosurgical TV. I'm in so and so and so. You know what I mean?
Yes.
You start the show and you basically run it, and I stay out of it, which I prefer to do. I prefer to try to
I
watch.
prefer you be there.
What's that?
I still prefer you be there.
Well, I'll be here, but not on the screen. Watching the technical stuff, like the sound and trying to get people in the panel. I can do both, but I prefer to have someone like you that works in the field of neurosurgery, obviously. I mean, it's better to have a neurosurgeon than moderate hosting, I find, because you kind of know where the flow is going. You understand it. And you would understand the conversation. So all the conversations I really don't understand. So how can I direct it? How can I add to it? I can't.
I see.
So anyways, it's something to think about.
Yeah.
I'll send you, let me send you the banner right now. Can you type your, excuse me, Oh, I'll put it in the chat. I'll put it right in the chat. Okay, hold on. Okay. Oh, actually, yeah. Yeah, there we go. Okay, I put it, Mohammed, I put the page on the chat.
I see, I got it.
You got it? Okay. So all you do, you know how to change the image on your
Yeah,
background, right?
yes.
So you can start tonight. You get that banner up. Or today. You doing okay, Mohammed?
Actually, I have to sign in, not just join the meeting. So I can join, I can sign in here in China, you know?
Oh, okay, okay.
Yeah.
So it's gonna take a little doing.
Yes, I
Okay.
have to open the
All right, no
VPN.
problem, no problem. I'll just introduce you.
Okay.
So how are things going with you?
All is good. I just arrived in Shanghai 3 days ago, you know?
Oh, you just arrived in Shanghai?
Yes.
Oh, good,
Yeah.
good. You've been trying, you haven't been there for a while, right?
Yes, almost 3 years, you know?
Oh, I thought you were somewhere else and you came there. Okay. Okay. Do you work in Dr. Bin's hospital?
Yes.
Oh,
I'm a
good.
member of his team, you know?
Oh, good, good.
Yeah, yeah. I
Yeah,
will
'cause he's
start with him. I will meet him for the first time next Monday. I mean, first time after I came back.
okay. Yeah, just
Yeah.
virtually you met him.
No, I met him. I was here in 2019, but because of the COVID, I left 2020 and
Okay.
stay in Egypt for 3 years. I couldn't make it to come back, you know.
Right. He's
Yeah,
been now.
yeah. So I mean, this is the first time I met him after I come to Shanghai.
Oh, okay. Maybe you can do some bypasses.
Hello,
Hey, Dr.
John.
Bit, how you
Hey,
doing?
hey.
We were
Hi.
just
Sure.
talking, about you. I
Yeah,
said, he's gonna meet you. And I said, maybe he'll give you a few bypasses.
yeah, yeah.
石老师你好。
你好，你好，你好，小莫。
So how many today?
9.
Nine. Well,
Hmm.
imagine that, Mohammed.
Sorry?
Imagine that.
Yeah, I have been there in the OR and saw him. You know, the first time I met Professor Ben, he did 10 bypasses a day, you know. That was the first time. That was in 2018 and 2017. And that time I told him, if I do master's degree in China, I will do it under your supervision.
Oh, okay.
Yeah.
Yes.
So I can guess the team prepares it, the team of residents prepares the brain,
Yeah.
correct?
Yeah, it's multiple ORs. It's not only one OR.
Yeah, right. I understand. It goes from one to the next, but
Yeah,
the
yeah.
residents prepare the field.
Yes.
The field,
Exactly.
so that he can go to the vital parts of doing the bypass.
Exactly.
Yeah, I don't know if you remember Michael DeBakey. He was a heart surgeon from Houston. He's one of the first ones that did a heart bypass, but he operated the similar. He'd go from one room to the next, and the residents prepare the heart, and they harvest the vein and get everything ready for him. Okay, here's Iris. Okay.
小莫，你再装个牙套，装了个牙套。
Yeah, yeah.
Okay.
Yeah. I just put it 3 days before my flight to China.
Oh.
Yes.
It seems that you are starting to speak again. They're starting to go online and do conferences. He's kind of quiet in a while because he was in Finland, I think.
Mm-hmm.
I
He
think
just
you're...
last week is his 75 birthday.
Oh, well, okay.
Yeah.
I know he was busy with a documentary that they were doing about him in Canada. I don't know if you heard about that. So I guess, well, you probably know more about it than me. I don't know if it's private filmmakers or what, I don't know. I just don't know if it was a professional thing. I was trying to get Dr. Lawton and him together. But you know, the schedules are difficult.
Yes.
So
too busy
to coordinate from halfway around. Here's Mike now. Yeah.
Hello, Mike.
See, let me just get in here.
Oh, sorry. Yeah. Hey, Ben.
Hi.
I was just looking at the schedule for Isman's, and I realized we're at the same meeting in Delhi next week.
Oh.
You guys going to India?
Yeah, India. Then I go to China after that. So.
Oh, okay. How you been, Mike? You been busy?
Yeah, as always. Doesn't really change.
Yeah. Yeah, neurosurgeons don't just hang out. Yeah, we got a few minutes, Mike. Oh, so Ben, you're leaving China to go to Delhi.
Hmm?
You're going to New Delhi for a conference?
No, not yet.
Oh,
We
okay.
couldn't go out. Yeah.
Yeah, he's probably doing it remotely, but
Yeah.
we're speaking at the same meeting.
Oh, okay.
Because I'm going through right now. You have to do a 7-day hotel quarantine and get COVID tested 6 times. So you got to really want to get into China badly.
Wow, 6 times.
Yeah, no, that's not joke. That's what you have to do. I literally just booked it right before this.
Oh. They pretty well stopped most of the testing here in Florida. I don't see any places anymore that do it.
Well, I mean, at some point, it's like, unless you're sick, we really need to know that you got a cold. I mean, if you're vaccinated, and you're young, that's basically what it is for the most people.
Yeah. Yeah, hopefully this will be a past chapter.
Oh, I mean, he'll be around for a while. I mean, we're not going to see the end of COVID in our lifetime, but at least it won't kill people. And the reality is, if you think about it, if you didn't get all these colds from childhood all the way on to, if you got your first cold at 70, it probably would do the same thing COVID did, which is wipe you out.
Yeah.
But the problem is you get vaccinated against that by nature so many times that by the time you encountered it as a 70-year-old, like, I've seen something like this before.
Mhm. Yeah. So you ready to start, Mike?
Yeah, whenever you are.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett, televising the excuse me, part 3 of a series of webcasts done by Michael Sughrue of Australia, and I'll let Mohammed Helmi, a neurosurgical resident from China, take over from here. Good morning, Mohammed.
Thank you, John. So, dear appreciated audience, we welcome you again in our 3rd episode of Seeing the Brain through Connectomics. This course is broadcasted under the patronage of Asian Congress of Neurosurgical Societies every Friday, 8 p.m. Indian time. So for those who didn't attend the first 2 webinars, we would like to inform you that the first webinar was discussing an introduction and network brain anatomy and how to make oncofunctional decision based on data. The second one talked about front temporal region surgery and how to do surgery in safer, better way in this region. The series of webinars is given by Professor Mike Sughrue, who is a neurosurgeon at Prince of Wales Hospital in Sydney, Australia, and he is the co-founder and chief medical officer at Omniscient Neurotechnology. Dear audience, you are welcome to write your question in Q&A box throughout the webinar, or raise your hand and ask your question directly to Professor Mike after the webinar. Professor Mike, thank you for joining us again, and go ahead, please.
All right, thanks everyone. So this week, actually, I don't know why I changed it, but I'll put the correct one. So we're going to talk about the parietal lobe. And the parietal lobe, at first glance, everyone kind of thinks that it's relatively okay. It's not the motor cortex, it's not the insula, it's not Broca's area. Now, the first time that I ever really rethought that in my career was as a resident. I was reading Yazergil's books, and he was talking about AVMs in the parietal lobe, and he said that they were the most dangerous cases that he did, and in many times he had thought about stopping operating on them. I thought that was very interesting. So what I'm going to basically do is hopefully give you some caution about the parietal lobe, that the anatomy is much more complex than you probably thought it was, but also give techniques on where are the safe angles, where are the places that you need to go slowly, where's the the function really? Where do you really hurt people? And particularly in the lateral parietal lobe, and particularly on the left side, the left lateral parietal lobe, the inferior parietal lobule, is one of the more dangerous parts of the brain to operate in. So I think we have to go through and understand why that is and what can we do. So again, we talked about frontotemporal surgery last time, and there's certain things that tend to run that. The central executive, salience, language system. On the other side, we have the parietal occipital region. And this is a different set of issues. There's some overlap. Language runs through the area. The ventral attention network, which is the right-sided analog of language, runs in the area. We haven't talked about that, but we'll talk about it. So a lot of similar things, but there's some differences. And the things on the right side of the screen form a working corridor. So if you leave one thing in this, there is a corridor in the parietal lobe that is relatively safe, and everything else, you don't want to take a trajectory through it. So if you don't have a reason to be there because the pathology is physically located in the rest of the parietal lobe, this is not the way to get to the deeper target. So that's why I'm going to try to show you that corridor, really make sure you grasp it, because it's the most important thing. So whether you're going to the ventricle, the thalamus, the corpus callosum in the back, wherever it is, if you're going through the cortex, the parietal lobe has a corridor that's relatively safe and a bunch of bad options. Now, again, let's talk about something we keep going over the course. Disconnections and trajectories share some things in common, but they're differences. So one of the things when I first started doing white matter courses, I got very excited about the idea of frontal surgery, but in many cases, people were just talking about trajectories. And I thought, well, what do you do when the tract is in the tumor or next to the tumor? And this is where the disconnection concept comes in. So some things in common, but things that are different because of what's the concept, what are you trying to do, and what are the cuts that are dangerous? Now, again, just like last week, if you watched this last week, we're going to keep hitting the same points. So skull-based surgery, very technically demanding, microsurgically, complex, high risk, but the anatomy is visible. Interaxial tumors seem very easy, but are not very easy if you're actually trying to preserve the anatomy. We're going to talk a lot about anatomy, and the real challenge is you don't see the anatomy. If you look on the picture on the right, everyone's kind of seen a blob like this. We know that there's incredibly complex anatomy in that little white stuff, but we don't see it. And that's the challenge. So while you might go in there, remove a tumor, think gross total resection, did great, patient did great, a lot of times that isn't always true. So in the book, and we kind of focused the first couple courses on covering context from the book, which is the glioma book. It's sold by Team, and I wrote a few years ago. But we'll move on into new topics next week, namely about how to actually use networks to reprogram the brain. That's what we're going to talk about next week. And then finally, we'll get into how the brain really works, the next level. But from a gross anatomic standpoint, oftentimes the decisions we make are not as nuanced as the decisions we make when we think about rewiring the brain. And what we covered last time are these disconnections: the medial frontal, lateral frontal, the posterior temporal, and the transinsular corridor. This week, we're going to cover that. Anterior occipital, medial parietal, and of course, lateral parietal. The big difference between these two and this one is these ones, you're working in the safe corridor, and here you're working in the bad area. So again, we're going to keep going over this anatomy over and over again, because what I want everyone who takes the course to gain is an understanding of how the brain is wired at a gross level, where the networks are, because this is new for most neurosurgeons. And we know a lot more about the anatomy than we did when I finished my residency actually now it's close to 11 years ago. So when we take the cerebral white matter, it basically lives in three columns. There's the medial column, which is the fornix and the cingulum and the corpus callosum. There's the lateral, which has multiple tracts, although most of the named ones are there. And there's the middle column. And now the medial column is basically a cingulum bundle running anterior posterior, and the corpus callosum wrapping around it. That's the medial system. The lateral system is largely going anterior posterior. That bends in some places, but that's basically what it's doing. And the middle column is going up and down. It's mostly the corticospinal tract and thalamic peduncle. running through tracks. Now, I want to really emphasize that tracks are not necessarily a real structure. So even though it looks like these things are running together, they're connecting areas that are not necessarily right immediately next to each other. But they're a starting point, because ultimately, when we look at the SLF arcuate, it's an anatomic structure you can dissect and see with the naked eye. It's just that many networks are connecting through that. Now, what you can see is that there's really 4 parts of it. If you get down to the anatomy, there's SLF 1, 2, and 3, and the arcuate. Now, you cannot, at least any reasonable person, I've never seen someone give a criteria of where one stops and the other one begins. And when we wrote our chapters on this, breaking it into the subcomponents is almost impossible. There's just too much crosstalk. But in general, the arcuate connects Broca's area to Wernicke's area and many other things around the sylvian fissure and makes a C. SLF2 makes a J, so it connects middle frontal gyrus to the posterior temporal region. SLF1 connects basically the stuff in front of the motor cortex in the midline, or sort of paramedian, to the stuff behind it. And again, these are very oversimplifications. And then SLF3 connects the operculum to the operculum. Now, we can get into details if you really want about exactly what all these things are. I've studied this a lot, but basically that's what this bundle is doing. And all those white dots in that picture on the left are all the things that it connects. So yes, it's not good to go through the middle of a bundle, but not all those white dots are important. And that's the difference between tracks and networks. So we don't want to cut through the middle of tracks. That's always bad, but not every twig that's coming off those tracks is equally important. Now, if we get to the infrafrontal occipital fasciculus, or IFOF, it's connecting a lot of the frontal lobe to a lot of the occipital lobe. But it's important to know that it's connecting higher level areas to early visual areas. So these areas are not getting very resolved visual areas. They're not connecting MT and MST, which are object recognition areas. It's not connecting the fusiform face area to the frontal lobe. It's connecting things like V1 and V2, which are very early visual areas. And what really is going on for the most part is the frontal lobe is telling the visual system what to focus on and what to process. It's called top-down regulation. That's probably what most of this tract is doing. And what that means is it has a lot of cognitive function. Now, again, we talked about this last time, that these two systems are bracketing the insula. Now, if you also look, there's lots of side branches that are coming off the tract. So some parts of it go to the intraparietal sulcus. And what I hope you can see from this diagram here, where the parts of the SLF are in different colors, is that even though these fibers are going together, they're really doing very different things in many cases. Now, when we bring in the inferior longitudinal fasciculus, this is connecting the visual system to the temporal pole. So it's basically the temporal version of IFOF. And these 3 bundles together make a wall. Okay, so they're developing all the fiber systems that are connecting many of the networks, and a lot of the cognitive system up are in the lateral area. So in general, coming from the side and going deep into the brain is probably not as good as working in the safe corridor. And of course, the deepest part of this layer is the optic radiations, which is the wall of the ventricle. Moving to the medial system, again, we covered all this last time. We're going to keep going over it. So essentially, if you look, there's the cingulum bundle. It's going around connecting different areas in the cingulate. Now, again, highly complicated. This is not as simple as that looks. And basically, if you look at here, you can see all these areas and fibers coming out of the cingulate. And then if you look in that middle panel, the corpus callosum on that diagram is in blue, and it's wrapped around the cingulum. Also, if you look at the very bottom, that's a very unique photo. And so if we zoom in on that photo real quick, you'll notice that the cingulum is running kind of almost like it's in a little wave, like it's a surfer going down the tube. And you can see that you have all these little green branches in the front and back. I hope that everyone starts to recognize that this is the default mode network. So before we had things like QuickTome that could map out the networks, this is how I used to try to get an idea about where it was, but not all of those fibers are going to the DMN. Also notice that this system connects all the way from the subgenual region in the front to the hippocampus in the back. And finally, that the corpus callosum is always wrapping around the default mode network. Again, if you're going into the callosum, the singular gyrus is not where you want to be for this reason. So you can see what the corpus callosum basically does is it connects non-cingulate areas, mostly a large portion of this near the midline, that are homologs. So superior frontal gyrus to superior frontal gyrus wrapping around the singular gyrus. Okay. Bottom of the screen, these little circles are ventricle. And this is where the corpus callosum is just this over and over and over again from front to back. And that's really important because this is the relationship that you must understand. You're going to follow a tumor into the corpus callosum. You can do it. There's nothing magical about the corpus callosum. If you enter the ventricle, you've already cut the fibers. But if you damage other things when you go in there, and these areas, there's no boundaries. You don't get to see this. You have to know, look at sulci, network maps, et cetera, to try to stay out of this area. Now, if you look at the system of the temporal opercular region, okay, so when we do lateral parietal tumors and we do in the supramarginal gyrus, we have to kind of understand how an operculum works and where the networks are. So you have the medial system in blue. This is the hippocampus, the parahippocampal gyrus, et cetera. And then you have the red system. This is where all those tracks like IFOF and arcuate and SLF, the optic radiations, they live in that red area. Now, if you don't, this is the temporal lobe, so it's much simpler here to understand. When we get to the supramarginal gyrus, the anatomy is much more complex. It's kind of like a little rotating wheel. And so you have to grasp this relationship because when you get to the back of the sylvian fissure, it's going to be a lot harder to know where you're at. Now, as I pointed out, tracks are just visible anatomy, but not all of it is important. So how do we know which one of those little branches we should not cut and which one of those branches we should cut? How do we know where to enter the brain? Well, in order to take that next step, you have to handle the brain thinking about how it's wired, which are networks. Now, those of you who've attended all the previous courses, networks are an observation that parts of the brain that are not next to each other synchronize their activity. They're not always firing exactly at the same time, but they fire a lot together. And that's because they're doing something in common. So again, the main types of networks, there are sensory motor type networks, there are visual type networks, there are limbic type networks. You have central executive, DMN, salience, and dorsal attention. Those are the big axes. But if you get more stringent, they split. So the language system, the cognitive parts of language are underneath the default mode network. So the DMN kind of interacts with the language system in complex ways. And remember that none of that's speech. Speech is a motor planning function. It's over on the right in sensory motor. And there's a few other areas, but speech is the motor production of language, and language is the cognitive component of it, right? And they interact obviously a lot. Now, if we split that up and you get that more detailed network, on the right, you see these networks are smaller and more confined. The yellow is default mode network. The brown is central executive core. The purple is salience, and the green is dorsal attention. There's also a pink network here, and that is called the ventral attention network. And we'll talk a lot about that because that is the right-sided analog of speech. A lot of the speech areas that we see are part of the bigger ventral attention network. And what we really want to get to with this is that obviously the brain is doing a lot of different things in the quote-unquote non-eloquent areas that we haven't been paying a lot of attention to. What the literature shows, and we've gone over this a couple of times, but I'll keep doing it, that this is a meta-analysis that we wrote showing that there are 550 papers in the last 10 years showing that damaging one of the core networks we just showed causes a cognitive, emotional, neurologic symptom, whether it's done by dysfunction or damage. And this is fundamental to mental illness, to Alzheimer's disease, exactly how the pathology causes cognitive issues. So most likely, if we cut through the middle of these, we are increasing the patient's chance of having a non-normal function after the surgery. So we should try to save these networks, even though we haven't been doing that in the past. If you need more proof of this, this is a paper of the Barrow. We've talked about it before, but basically going through networks is bad. That's what you're seeing there. Now, let's go through the main networks. Now, language is not a pure network. It's mostly default mode. This map here is a little bit different. This is when we put into QuickTone. It has language components, but it also has speech components. The one thing that, again, I want to emphasize is that the Broca-Wernicke model isn't wrong. It's just very, very simple, and it doesn't keep us out of trouble. There are parietal areas. You see here PF, that's in the supramarginal gyrus. That does a part of the language system. That's part known as the Geschwin's area. And you see 55B, that used to be called Exner's area, but we forgot about it. It disappeared for decades. And we now rediscovered it through the Connectome project, where it is clearly a new language area that is probably a motor cortex of the larynx. Now, if you go to the more pure networks, default mode is a 3-part network. And what it does is when you think to yourself, or internal mental processes, when you imagine things, when you try to make new memories, the default mode network is part of it. And it is a very important network. It probably is the big kahuna as far as cognitive organization. So I'll give you 2 things that can confirm that. Number one, it's very uncommon for someone to have clinical Alzheimer's disease and have a normal DMN. It's actually probably required that the disease spread into the DMN for you to start having symptoms and memory. In fact, that's actually where it shows up first. Part of it is because these parts of the brain use a lot more energy than other parts. The posterior cingulate, for example, is one of the more energetically active parts of the brain. It's called a rich club. Now, that posterior cingulate is going to be critical to operating in the parietal lobe, and it takes up a large part of the precuneus. If you look at the other parts, there's a lateral parietal component. This seems to be important, but less important. So you can sometimes violate this, but it's better not to. Better to go, if you go somewhere else, go somewhere else. But that anterior cingulate, I can promise you, is actually both of the anterior and posterior cingulate. If you want good outcomes, try to remain out of that area as much to the extent possible. It should not be your first choice. Now, if you look at the salience network, you have a middle cingulate and anterior insula component. And what the salience network does, the way to think about it, the insula, particularly the upper boundary of the insula, is involved in parsing the internal world. So it understands heartbeat and stress, and talks to the amygdala, and also all the intestines. It feels them. Now, the middle cingulate is a decider. It makes decisions on what your actions are, and they need to talk to each other to snap you into action, or to change your heart rate and other things to address a stressor. Now, most importantly, the salience network, the way to think about it is when you need to turn the DMN on off and get into action, the salience network is the initiator. That's what it does. But it does a lot of other things. And it really is whether or not you are salient to a function. So if you basically, a lot of the patients who are very, very sensitive, they have fibromyalgia, or they have chronic back pain, or everything is, they have all these symptoms and they have a tiny arachnoid cyst. We all know who these patients are. They're very common. So it's shown that many of them have abnormalities in the salience network. That's probably why they notice things, and also why they have intestinal complaints of various kinds. So it's not really psychosomatic, it's salience, right? Now that we have a better term for that than just a vague term like psychosomatic dysfunction. Now, when we get to the central executive, it starts at the frontal pole. There's an area in the frontal lobe called 8C. That is one of the most connected parts of the human brain, and it's the epicenter of the CEN. So the frontal pole, as we know, you can sometimes violate it, though it's generally, particularly on the right side, it's best to not. But 8C is where you and PFM need to talk to each other, or you're hurting the CEN. And that's going to be a big issue, because the P in that PFM stands for parietal. In fact, that if you get down to it, all the P things that have a big P at the beginning of the parcellation name are parietal area. Whereas if you look on the left, that's Brodmann area 46, Brodmann area 8, and Brodmann area 47. So that if you just to learn the nomenclature, we can go, if anyone's interested, I can explain to you how the HCP nomenclature works. It's learnable, but you don't have to learn it to gain something from connectomics. Now, if you're in the parietal lobe, the dorsal attention network is one of the key players. So I went through this a little bit briefly in previous ones, but here it's very important. Okay, so let's get an understanding it. Salience network is an insula thing. It doesn't really show up in parietal tumors. If you're in the salience network in a parietal tumor, either it's an enormous tumor or you've done something terrible. But in this case, the dorsal attention network is involved in maintaining attention. Okay, so how does it do that? Well, you have three parts. You have the interparietal sulcus in the middle, frontal eye fields, and a motor planning area. Area 6A is part of Brodmann area 6. And then it has visual areas. That's the stuff in the bottom right, MT and MST. These are things that really are high degree of resolution. So if you think about this works, so the IP areas, see VIP, AIP, those are intraparietal sulcus areas. And what the interparietal sulcus does, particularly the superior bank, is it keeps tabs on where everything is located in three-dimensional space. So if you think about it, how do you incorporate hearing, touch, proprioception, vision into one world? That's kind of what the interparietal sulcus is doing. Now, in macaques, these things are named for the anterior bank of it, or the ventral medial bank, et cetera. But in humans, the inferior parietal lobule expanded significantly. And most of the intraparietal lobular areas, cytoarchitecturally, if you read Brodmann's Atlas, if you go trace it around, don't exist in chimps and other monkeys. It's unique to humans. So when it expanded, all the interparietal areas got pushed to the superior parietal lobule. So area 7 is not in the SPL in most animals, but it is in humans. So are all the interparietal areas. But the bottom line is that key thing is this: sometimes going down a sulcus is a good idea, but given that frontal eye field, area 55B, and all these interparietal areas that are part of how things are in space sit at the bottom of sulci, I really have to suggest that not all sulci are better than all gyri. There's sometimes it's better to take a longer path through a gyrus. Remember that the bottom of sulcus is brain. It's a brain area. And the bottom of the interparietal sulcus is the hub of the dorsal attention network. Now, what happens if you injure the dorsal attention network? Well, it's hard to say, because if you look between the IP areas and the frontal eye field, it's the motor cortex. So very few people injure this in isolation. But what we seem to think is that if you can't keep your eyes focused on something, because if you look at this, that's what it's doing. IP note gives where everything's at. Frontal eye field, the visual areas is visual information, and the frontal eye fields keep you focused on it. It's hard to read. If you damage it, it's hard to read. It's hard to function, and people's IQ probably drops. Now, there's a parent or a relative network that we haven't talked a lot about, but it's critical for this area. And this is the ventral attention network. Now, the ventral attention network is not exactly like the speech network, but for purposes of doing surgery in the parietal lobe, I like to think of it that way, because a lot of the maneuvers that I do to save the language system, a lot of the paths that I save also apply in the ventral attention network. So when we program QuickTone, anywhere we put the language on the left side, we put ventral attention on the right. And there's a couple things that are important. So when we start talking about neglect, this is a complex function. But the way to think about the ventral attention network is it switches your attention between tasks. So if you need to go look at something new, i.e. not neglect it, you need a part of the brain that switches your attention. And for a long time, we have known for over 100 years that neglect is in the right side of the brain, and mainly in the parietal lobe is the main place that happens, though there are lots of other places you can cause neglect, like the frontal lobe. But the parietal lobe right parietal lobe is the classic description of it. But up until we knew the ventral attention network, there was no guidance on what was safe to do in the right parietal lobe and what's not. And of course, if we don't know what's the danger zone, then we're going to walk into it all the time. And so we've done awake surgery with maps of the ventral attention network. We've done it with target cancellation in awake patients, and which is a pure neglect task. We're pretty close to one. And in general, if you basically stay out of this and the SLF that connects it, neglect doesn't really happen. So it's an avoidable problem. And again, sometimes there's tumor in it and you don't always need to save it, but it's a real step forward that we actually now start to know exactly what we're here not to cut. Finally, if you talk about the sensory motor network, as we talked about many times now, it's a network. So saving the motor cortex is great, but if you destroy the planning areas or you cut the sensory system, or worse, you go down the central sulcus and you disconnect the motor strip from the sensory strip, oftentimes people will move all four. We give the thumbs up, good job, but they don't really have normal motor function. Remember, SMA recovers, but it doesn't recover to make people Olympic athletes very often. And so I think a real key thing when we start thinking about why should we focus on preserving the sensory cortex. Now, if I have a choice, I'd take the sensory cortex over the motor cortex. I'd rather go through that. But we should take it a little more seriously than we have, because even though someone might not be totally numb in their hand, losing coordination and proprioceptive function from sensory feedback is a big deal. And the way we know it's a big deal is that for probably close to 15 years, there have been papers. I think the original Nature paper, if I'm wrong, someone can correct me, but it was somewhere around 2007, 2008, where people show that you can get an implant and have a paralyzed person drive a mechanical arm with thoughts, okay? Now, the question is, why do we not do that on every quadriplegic patient? Or every with ALS, give them all implants. And it's very simple, because if you have a hand without proprioception and you move it around and you don't know where it's at, you just knock things over and you're uncoordinated. And I think a really key point is when you reach for a glass, your hand shapes the size of the glass. Well, there's visual input, there's proprioceptive input, there's things necessary to do that. So when we give somebody who's just able to do a thumbs up, but if they can't meaningfully use their hand because you've destroyed their coordination, this is still not really a high five win. So we can't always save all this stuff, but we need to think really hard about the sensory motor system as a network. And that's really what we're showing here. So when we do a disconnection type surgery, we have the three Ds, and one of them is define, divide, and destroy. Now, what this basically does is it puts the angle around the disconnection. This is where you cut between the tumor and the brain. So again, there are a lot of ways to do surgery. I like to go for the dangerous parts that cut next to the network early, because my mind is fresh. If I'm doing awake, the patient's fresh, and the image guidance is fresh. It's the closest to accurate. And so there's no reason to do the dangerous things when the image guidance is the worst and you've been operating for 6 hours. But plus, once you've divided the tumor from the brain, it's just microsurgery. It's like taking out a meningioma or a brain metastasis. You just remove the brain. So getting specifically to the parietal lobe, the dominant features that define the corridor, and you're looking at them, you have the sensory motor system. It makes a nice coronal shaped wall, okay? So generally that's almost always the front of whatever procedure you're doing, no matter where you are in the parietal lobe. And you want to try to preserve that coronal plane. Now, it doesn't mean you can't do it. You can go into it. You can take tumors out of the motor cortex. But if you had your choice, it's best to not. And then you have the dorsal attention network and either the ventral attention network or the language system. These guys form a lateral wall, okay? You have the default mode network in the medial side, and then the optic radiations are often kind of down over here. So they also form part of this lateral wall. And so what you end up getting is a corridor that looks like that, okay? So we're generally, you have the language, the ventral attention, the dorsal attention. These are all running through the parts of the superior longitudinal fasciculus, and you want to be medial to it. If you preserve that system, you also preserve IFOF and ILF, though there's exceptions to it. It's very hard to cut through the IFOF without cutting through something else, right? They're sandwiched together here. And if you're taking out occipital lobe, well, if you're cutting out parts of the IFOF, unless you're really deep around the ventricle, then the fibers are terminating where in the gyrus you're operating in. So remember, you're going to cut white matter somewhere. What you don't want to do is cut something that's connecting two parts of the brain that are not where you're operating. So that little blue area is your safe corridor. Now, I call this way to think about it, there's different disconnections that you can do that take advantage of that corridor. Now, the medial parietal disconnection is my workhorse. This is one of the most common things that I do in the parietal lobe when I do big cancer operations. I do trajectories, I do variations on this. So obviously I don't move the entire parietal lobe to get to the atrium and lateral ventricle, but staying in that gray area at the top where you're working between the cingulum and the SLF. Okay, so let's go back. The green is the cingulum bundle and it's the default mode network. Okay, cingulum, green, default mode. That lateral system in yellow, that's the ventral tension or language. And in the red area there, you have the optic radiation. So that's a lateral wall. So generally, if you stay medial to the intraparietal sulcus, remember we talked about that, you don't want to be there, and you stay lateral to the default mode, and you stay behind the motor cortex, that area there is one of the more tolerant parts of the brain. We can go into reasons why, but the networks tend to be redundant. There's not really known neuropsychological deficits that are unilateral. And so this is a great place to be whenever possible. And so we'll talk about a couple different ways that you utilize this. But basically, when you do a medial parietal disconnection, the most dangerous cuts are the default mode, the motor strip, and the lateral systems, meaning IFOF, SLF type things, i.e. dorsal tension, language, and ventral tension. Okay. Now, if you have entered this approach, remember that it doesn't always have to be a medial parietal lobectomy. You can do a lot of other things. You can go into the splenium of the corpus callosum. It's key to note that you're looking at that angle there. Okay, and sometimes a lot of these tumors go into that. There's once you've entered the ventricle, guess what? You've cut the splenium of the corpus callosum. Just because you didn't cut it where you saw it, you cut it deep in the white matter. If the fiber doesn't connect, it doesn't. But more importantly, when you have to follow tumors that are extending into the medial temporal structures, this is a great way to have the proper angle. So I go through a few cases. So in this case, again, this is older. This is before we had quicktome. You can see this is the parietal lobe in the front. Now this is glioblastoma. You can see it coming to the surface here. The sensory cortex, and we've done a wake mapping, so you can see those are the numbers, and I put some things there. We've seen neglect at that number 1. And again, it's exactly where the imaging expects the ventral tension network to be. You can see that blue, that's part of the supramarginal gyrus. So the angular gyrus is on the upper right, supramarginal gyrus on the upper left. And you can see the beginning of the intraparietal sulcus, though it's very expanded with cancer. So we want to basically, at the bare minimum, be behind that yellow stuff. And ideally, to preserve the lateral wall of the atrium and lateral ventricle. Now, sometimes there's a field cut and you can't do that, or shouldn't even waste your time doing it. But if you look here, let's just go through it now. So we've already defined this, and we're going to start to do our division. Okay, now this is a pretty substantial division. You can see this is all cancer. And our key thing is to maintain the attention networks, which are going anterior and lateral to this. Okay. Let's go a little further here. Now, I want to show one thing here, right? So you can see that there's that artery going posteriorly. Now, the first thing you want to do is when you're in the angular gyrus, supramarginal gyrus, they make this really complex peel twisting as they head into the back of the sylvian fissure. And what people make the mistake that they try to dodge around this or do this in a certain order. You actually want to make this operation into a single cavity. So I really recommend spending the time to subpealize all the gyri and sulci and make it into a single cavity. This is actually just an approach that I learned from doing skull base, right? So the most important thing with petroglyphal meningiomas is drill the petrous apex, or what direction you're coming from, cut the tent, and make everything into a single cavity so that you can see what you're doing and really make sure you get the whole tumor out. So you can see here the cut. I made this cut in the front with the SLF. That's where those telphas are. We're making our cut. We made our cut with the sensory motor system, and now we're just amputating this down to the top of the ventricle. Okay, so you can see that. And there's the atrium. So I know that once I see the ventricle, I can't veer laterally into this system. Now, Don't always have to go in the ventricle. This tumor happened to go down to the ventricle and into the optic radiations. But the point of it is, you see how just because I find the ventricle doesn't mean I'm done. And, I make sure that I get across that. You can see where the fibers are left. And then the back wall of the ventricle, the part that's going between the ventricle and the falx, is the spleen and the corpus callosum. But the sulcus behind that is the cingulate gyrus. That's the default mode, and you want to stay out of that. So that's the quarter. So you don't see the DMN until you get late in the operation. You have to continue to think about it. It's on your blind side in this approach. Notice that we got the cut all the way across. Most importantly, turning everything into a single cavity. Okay. Now, again, once you've entered the ventricle, though, you can go into the corpus callosum. We didn't in this particular operation, but I think one of the most important things that I can teach you on this is, let's say you've actually done a fairly decent resection and the tumor just goes along the hippocampus for a while. Now, if you remember last time, once you are past the language system or past the ventral attention network and you're into the medial part of the temporal lobe, it's a different system. So if you're in the ventricle, everything medial to you is reasonably safe as long as you don't get lost and get into the basal ganglia or something. And this is equally true if you come from the back. So you can actually remove the entire hippocampus from this approach. In fact, it's actually easier. So when you deal with tumors that are these big, complex, multi-lobar things, your real question is, do I want to be behind the system or in front of the system? By the system, I mean dorsal tension, ventral tension, language, IFOF, these kind of things. So there's another case, right? So this is supramarginal gyrus. You can see this is where the SLF complex is. You can see the veins, the superior parietal lobule at the top of the screen. And again, our first goal, define the anatomy and then work to subpelize supramarginal gyrus to make everything into a single cavity. So I don't want to go in there and accidentally hit an MCA vessel. I also don't want to get lost into the insula or get deep into the atrium and not know I'm doing it. All these things. And so really it's knowing, use your insula as a depth gauge. So you can see here, we're just working, we've subpelialized that gyrus first. Notice that part of it is I want to know where the insula is. I want to know, make my disconnection with the SLF. And I use my intraoperative mapping and all these other things to know where to put that cut. Notice I haven't touched anything else. You'll see that we do a pretty big resection here. Now, I've done that cut with the lateral system first. Now I want to cut with the motor system in the front. So that's the second part of this cut. The third part of this cut is on your blind side. You need to find the cingulate sulcus, but we're not there yet. Once you start getting near the midline, that's when you need to start knowing where's the cingulate gyrus, where's the default mode. But see, first we got to get this disconnected up front, right? And again, while we're doing this, we're actually monitoring for neglect. We're doing target cancellation tasks. We published this at Resource Online many years ago. But the key thing about it is, again, you don't see any anatomy here. It's just a blob. You have to know where it's basically at. And more importantly, how did I know I could take this gyrus out and there wouldn't be neglect, but in front of there was? Well, imaging, right? And intraoperative testing. So I'm just going a little bit ahead here. You can see there's the tent, falx, etc. Now, when I'm folding this tumor in, you notice that I can be very aggressive at this big piece, but what I don't want to do is remove the cingulate gyrus, right? Again, we're doing a very big cancer operation here, but I'm going to stay out of this default mode as much as I can because, so what I'm here is I'm looking, I've identified the cingulate sulcus, I'm going to make a cut that parallels it. And you see this? This is when I'm done, I've dried everything up. The SLF is running through here. This is the ventral attention network, motor system in the front. You see we've done basically a simple lobectomy here because this is all cancer. But notice that I left the posterior cingulate. Now, if you look in the middle, corpus callosum is there. So I want to keep the cingulate intact and connected interiorly and back around unless I have a real reason to remove it. So that's what you're looking at here. And again, How did I know this? I found the cingulate sulcus, and then I was running along the falx, and then I cut and I moved laterally and went around it. Okay, so I stopped, cut, went around it. Okay. Now, if you look here, these diagrams show, well, what if you're dealing with butterfly glioma that's crossing the midline? And it's important to know what butterfly means, right? So there are tumors that are primarily in the corpus callosum. I'd say those are true butterflies. They're really only butterflies. And here you see this is us taking a fairly tailored approach to it. Now, the challenge here is the following, right? If you were to try to take the most easy approach to getting this tumor, you would actually come straight from the side. You'd go right down the long axis of this tumor. And that basically means you're looking down the barrel of the corpus callosum. You're looking from left to right. But if you're paying attention, you should probably never do that. And the reason is, unless there's these are already destroyed by cancer, and at which point you have to ask what you're trying to accomplish here. But the problem is that the lateral system, the language system, the deep dorsal tension, they're always going to push you backwards, and they're going to push you off that axis. So there's a couple of tricks you can do to make the curve as you go to the other side. So you can almost always get an ipsilateral complete resection. Notice in the lower right, we've saved the default mode network. You can see the cingulate saved. Again, highly recommended. But it's going to make a bend around the falx. So there's things you can do with endoscopes. But what I've actually found that works the best is getting the bigger side done surgically and then using laser ablation on the other side to get the tail. And that seems to work really well because you don't mess with the other side. You're not working some difficult, heroic endoscopic angle, et cetera. But either way, key thing is that you look at that's an angle of how to make that turn. Okay, so you can see here, again, a corpus callosum tumor is a smaller opening. We're not working on the surface. We're taking a trajectory to this. The disconnection is deep in here. So you see, I want to be farther back and I want to stay in the safe corridor. I don't have any reason to be out there cutting next to the arcuate like I was doing in those other cases. And so I'm just going to go down really quickly, do a corticectomy, find the tumor. Now notice that as you go deeper, you get more degrees of freedom. So superficial stuff needs a big craniotomy that exposes the surface. Deep stuff does not. That's the keyhole principle. We wrote a whole book on that if you'd like to read it. Now if you look at this, right? So we made a cut here laterally with the intraparietal sulcus. In the front, we want to stay at the sensory strip. Now this is actually a cingulate gyrus tumor. Now I remember this. And the main issue is that, again, if there's tumor in the cingulate, sometimes you can resect it. But if there's not, you generally want to go around it. So when you see that you're getting in the posterior cingulate, now what you can do is if you're in the posterior cingulate, if you decided you're going to go in there, let's say there was glioblastoma following the cingulate gyrus, but you can work under the motor cortex. Remember that these areas don't really talk to each other. So as long as you stay in this little tunnel, you're fine. And this is how to remove a posterior cingulate tumor that's going under the motor cortex. You can see that's unhealthy stuff that you don't want in their brain. And okay, now going further inferior, this is the anterior occipital approach. Now you can see what we're doing is we're cutting behind the yellow system. The yellow system is the SLF system. And again, that is dorsal tension, ventral tension, language. Now, this on the left side, this approach will often has a risk of running alexia because the visual system needs to talk through this little lateral area to the Wernicke's area. Having said that, if you have a patient that has this already, or this isn't an issue, or at least their problems, or you're picking the least bad way to get this tumor out, then that may be something that you just have to do. Actually, the case I'm going to show in a second, way to do this. So generally, I like to be in front of the system, not behind it. But sometimes you can get through the system, and they don't all develop speech or reading problems. But that's kind of where that part of the brain lives. Now, again, The difference in the anterior occipital approach and the posterior temporal approach is in front of the system, and the anterior occipital approach is behind the system. Okay. Both of these get you the ventricle. Both of them get you the hippocampus. Remember, as I talked about earlier, once you're in the hippocampus, you can follow it all the way forward. So this is a posterior temporal case. Now, what I want to show you, or anterior occipital case. So the patient is on the left side. You can see this anterior, and all of those little squares are naming sites. Now, what we know is they need to go two directions. They need to go anteriorly to the mid-temporal gyrus, and they need to go up to the SLF where that arrow is. Okay, so they need to go to the other parts of the language system. So the tumor is filling everything to the left of that. You can see where that little biopsy site is. And our job is to work underneath that and preserve that continuity. So we must be behind the system. This is the thing that's going to be less damaging. Now, if it's a big temporal polar tumor, you want to be in front of the system. And that's why you need to think about, which side you. Posteriorly, this patient had a complete. So you can see here, this patient was preoperative alexic, and you can see that essentially I'm padding that language system and trying to work underneath it as much as I can. I'm trying to just keep it intact. See all this nasty glioblastoma. And again, you can see this is the cut. Now, once you get to the ventricle, again, the lateral temporal system is in front of you, or it's lateral to you, so it's not running through the ventricle. You can work underneath that a long way. You can go all the way to the amygdala if you wish, if you spend enough time with this. But here you can see we didn't need to do that. And I'll just spare everyone the troubles, lots of removing stuff that bleeds on you. And that's the final resection, right? Now notice at this point, the image guidance is off. That's why you want to do that cut when it's not off. And that's why do the dangerous part first. Now, what if it's in the inferior parietal lobule? I hope that I've explained to everybody why that is bad. Not only are there fiber bundles, but the default mode has a node there. The central executive has a node there. There's language areas there, ventral tension. It's a lot of stuff going through there. And furthermore, if you keep going too deep, you get into the optic radiations, IFOF, the internal capsule if you want. There's a lot of things you can do if you get lost here. And finally, there's a ton of vessels that are coming off here, and most of them are not ones that you can do too many things to. In fact, if you look at, there's a branch where that arrow is on the top right, that's just a branch that's very sensitive to manipulation. So sometimes you can actually get a stroke from just messing with it too much. And on the left side, this is usually a stroke that causes an aphasia. So when you deal with this case, the most important first thing is you need to acknowledge that you're doing something dangerous. So if you look at those other operations, we're doing a big cut, we're removing big pieces because we're in a safe corridor. Here, we're not in a safe corridor. There's a lot of stuff here. And so you can see that the first thing I try to do is find the insula. I don't want to go too deep. I don't want to get lost. I don't want to get into putamen. And also, the most important thing I could tell you is don't cut tracks that are connecting things that are not where you're operating. And the way to not do that is don't go below the sulcal boundary if you don't have to. So the risk is in the deep white matter. If you're above that, all the white matter that you're cutting is going to that gyrus. But if you go deep, you get into the bundles that are connecting other things. You destroy entire networks at multiple ones at a time. So you really want to stay above the sulcus. And that's pretty easy to do in most places with careful subpelalization. But as I pointed out, supramarginal gyrus, we wrote a paper on this a couple of years ago, does a kind of swiveling pattern. And that's because it's the anchoring point where the brain bent. So what you want to do is work to subpelize, and now to work between the vessels so that anything you do deep to that, if you look at the very bottom here, I'll show you what that picture is showing you. I made it to a single cavity, okay? So what you do not want to do is go deep in there, work in a deep dark hole. You don't see anything and then you get lost, okay? And that's easy to do, and this is not where you want to get lost. Let me get back to this. And so if you look here, so we're here on the left side, okay? You see there's the motor cortex, there's a naming site, And then at the confluence of that vein is supramarginal gyrus. That's where the SCG is going in the supramarginal gyrus, and the cancer is in there. So we got some challenges. Okay, we want to, in general, we're surrounded by everything. We would actually want to be further back or further forward from here. This isn't where we want to be operating. So, but that's not what we don't have a choice here. So that's where the tumor is. So point one, we've defined this, the definition phase. The cortical mapping is done. We kind of know where the gyri and sulci are. We've identified arteries. And you see that we're going to start taking down the supramarginal gyrus. We're going to take down a part that hasn't caused any obvious speech motor type problems. Now, this may have cognitive issues of central executive, but on the scale of things, you know, it's a hard challenge, right? There's no easy or pleasant place to be with a tumor like this. But what we don't want to do is get deeper in and remove multiple parts of the CN, cut tracks that are going somewhere else. We don't want to cause a stroke. And we don't want to get lost where we just, you know, do a sharp bite of this tumor. If we're going to take this out, let's really take it out. So you can see that we're just subpializing between the vessels. See that? It's a single cavity. You can see everything, and it gives you a lot of room to work. So you see that? If I didn't have a single cavity, I might have missed that artery and just nailed it in the wrong time. And it gives me a sense, where's the insula? Where are the white matter pathways going to be? Okay. And you, at this point, now you're really starting to do the actual dangerous stuff, the disconnection, et cetera. But most important thing is by not being, you know, too aggressive going in there before you're ready, making it into a single cavity, you can get a better sense of what you're doing. And this is just us looking deep in here and finishing the tumor section off. Now, in this case, there was also a trapped ventricle. You see, we put a stent in the temporal horn there to keep it open, because of previous surgery, a previous hemorrhage, et cetera. So the bottom line is, and what I want to do after this is I'll actually take everyone through planning a case like this. The bottom line is, again, where networks come into the situation is getting an idea what your trade-offs are, what are you dealing with, thinking about how do we use microsurgical technique, things like making a cavity, knowing how to, you know, work between certain areas, but also knowing that removing the cingulate gyrus is a bad thing. And that's the combination of taking what we know and not starting from scratch, but also adding things about what are trade-offs. And in that last case, if she has something supramarginal gyrus on the left side, it's glioblastoma, it's least of your problems. But what you need to think about is you wouldn't want to pick that as an approach for a much simpler case where you had other options. So this is QuickTome. We're going to run through the anterior occipital approach because I have a pretty good case of this. And so we picked the left anterior occipital angle, just to show everyone the case here. This is, you can see here, it's a T2, but anyone who's reasonably experienced taking a course like this most likely can recognize that's a glioblastoma here on the T2. It has kind of a bifocal, so it's kind of two little nodules across at it. And the shortest distance to the end of the tumor is that. Now, again, shortest distance is sometimes not the best, right? And that's not one of the other challenges is that's not down the long axis. So it's going to be loading some fibers up, but we don't need that to look at where QuickTone predicts the network. So let's start off with the language network. Okay. So again, the tracks haven't loaded yet, but you have Wernicke's area in white, Geschwin's area in purple, Broca's area in green. The dark green thing here is 55B. You can see there's SMA. Now, obviously, some of these things are way away from us. But at the end of this operation, we want the white thing going up and connecting to Broca's area, okay? And if we look at that angle, the shortest path cuts it awful close, right? That's the angle that you're doing this at, right? And so that's not optimal, but it's even worse when you look at the dorsal tension, right? So zooming out the dorsal tension, if you remember the anatomy here, the green thing is the first part, frontal eye field. Then this is the interparietal sulcus component. You see those little ones in the back. And the latter part's the visual component. Now, if you want to get a grasp on what I always tell people is if you think you can't make a patient worse by operating in the motor cortex because they're paralyzed, see there's the motor cortex, keep an eye on that. And then we're going to go back to the dorsal attention network. Yeah, you can always make them worse because these two things talk underneath the motor cortex. See that? So the dorsal attention network, if we look at this part, it, essentially your approach goes right to the middle of that node. Now, you could get into this argument saying, well, it's glioblastoma, should we bother with that kind of thing? Maybe it's already damaged. But the reality is that if you basically take a slightly longer corticectomy, you get two advantages on this angle. Now, the first is you don't go through in the middle of any networks, so you can totally avoid that. And the second is you're working on the long axis of the tumor. And in fact, if you keep looking, as I pointed out a couple times, there's the amygdala. So you can just keep following that all the way there if you wish. Now, the main thing is if you choose to do that, is you need to stay medial to the ventricle, right? You don't want to get off into this lateral system because this is the kind of stuff that's in the lateral system. You got that. There's your parts of your ILF here. Let me just zoom up a little bit on that. So you see how that system is running out laterally. So now you can ask, are you going to injure the ILF here? And the answer is yes and no, right? We know that the ILF is going to where this tumor is located. Having said that, again, if you look really closely, it's not, if you remove that bottom part, you're not really disconnecting very much from very many other things, right? That's the temporal pole part. That's the occipital pole part. And the fibers you're looking at that are investing in this tumor are local fibers. They're not this center of the bundle. So again, you're always picking the least bad approach here, but that kind of gives you an idea. So ultimately, in this case, you would choose the interoccipital approach because the other approach is the posterior temporal approach is longer, it's off axis, and sometimes cutting through more brain is better if it's the right angle. But also, I hope I've taught you that you have this fundamental working corridor, whether you're coming from the parietal side, temporal side, or whatever, this little space here, right? Keep showing you where these networks are located. And then let's put another one on here, which isn't part of this montage, just to show you for educational purposes, this is the default mode network. Now, again, if you have to prioritize parts of the network, the lateral parietal component, again, that's the inferior parietal lobule. Remember, I told you it's a lot of dangerous stuff in the inferior parietal lobule, especially on the left side. But if you had to prioritize, because both of them are in your way, let's turn off the other side. We can actually turn off the parietal components here. So we just did that. And this is lateral parietal, interparietal sulcus. So what you get then is you really, when you say save the DMN, you want to stay in this corridor. And you can see that it's going down into the hippocampus too. You see that? The DMN is somewhat complex, but this is how we chose to render it in QuickTone. So I think that's the key take-home message from all of these is how do you make decisions with connectomics? First, you have to know the anatomy. And again, I went over it a couple of times. We'll probably do it next week too, so that everyone knows where the networks are. The second is you have to use the existing skills you have, but updating new ideas of what are the trade-offs that you're really making, what happens if you go through these networks, and what are ways that generally you don't go through these networks whenever possible. And again, if this was in the default mode network or as a butterfly glioma, and just to show you what that looks like here. So you can see there's a butterfly GBM posteriorly. And when you get into those kind of rough situations, sometimes you don't have a choice. You're picking the least bad path. But also, if you know that that's what the problem is, we can be careful, right? We're going to slow down when we think the facial nerve is in an acoustic neuroma. But some parts of the tumor, if you're very experienced, you can take them out in big pieces. You don't need to be extremely delicate with the lateral parts of a butterfly or a acoustic neuroma. And that's similar here, right? So if you know that the DMN, for example, just to get to the where that is. So you have this big butterfly GBM. It's actually a non-contrast image. but you can see that what this tumor is doing. See, there's the DMN on one side. Let's make it actually both sides. So you see that little purple thing, that's the DMN, right? And you see that this tumor is wrapped around it. So basically, in this particular case, knowing that that's the key part of this operation changes the operation. It also makes it possible to do this and have a reasonable result. All right, thanks, guys. And we'll get to questions.
Yes, thank you so much, Professor Mike. Actually, I have a question. How serious is a minimal manipulation of this network is? And as you know, there is no comprehensive cognitive test. So how can you evaluate the damage, if any?
I'll answer the second one first. Increasingly, there are many good iPad-based apps. Now, depending on what language you're in, so the major ones, Chinese, English, Spanish, they have neuropsych batteries. But increasingly, while a 5-hour neuropsych battery sounds great, the problem is most patients can't tolerate it, and we don't have enough neuropsychologists in the world to cover what we really should be doing. So the future of that is apps and or giving someone at least a pen and paper and just making it part of, while they're waiting in clinic to see you, they do one of these. As far as the manipulation of the networks, there's a lot that we don't know right now. Okay, so what we know from the literature, which is fairly extensive, is that there are consequences to cutting these, and they're cognitive, emotional, sometimes neurologic. Okay, so the dorsal attention network, people have glazed over eyes, but they still can move everything, so they get the neurosurgical thumbs up, but that's not really quality of life. But what we don't know is what part of what network. What I can tell you is, when I've done awake surgery for some things, when you touch the salience network, people just stop doing what they're doing. That I can tell you that. I have videos of it. I've seen it a dozen times now, to where I know when I'm getting close to the salience network in an awake patient. So cortical mapping, generally not that useful, because in part, you're actually, for salience network in the middle cingulate, you're actually usually coming from the blind side. I mean, I guess you could do an interhemispheric approach and stimulate it, but that's usually not what you would be doing. I think on the other hand, what I use it in awake surgery in that situation is monitoring. So it tells me I need to slow down. So it's like the facial nerve monitor going off. And we just know that the salience network is very old in evolution. It goes back early in mammals, probably earlier. We know that it does a lot of important things necessary for initiation. The SMA is mostly salience network. And just having seen people literally drop what they're doing the second you touch it and then stop doing that when you take the thing off, then it starts to tell you that there's probably some important function to that area. But we're still going to keep learning of what we can get away with. Remember, it took years to get to the point where we knew how close you could get to the language area without hurting them.
Okay, thank you. Professor Ben, do you have any questions?
Yeah, I think Dr. Hashar, he has a question.
Oh, yeah. Yeah, there is a question from Dr. Hashad from Mumbai. He asked, you localize all these vital areas in surface of brain in awake surgery? If so, then after mapping, do you give anesthesia?
So what I'll say is this. What we know with pretty good certainty is that doing stimulation mapping is pretty good for speech. It's pretty much gold standard for finding language areas and staying out of them. It's great for motor. You can do some visual testing. Neglect, I think you can do, and you can monitor someone. Those are things that I'll hang my hat on and say that works. When we get to higher cognitive function, like fluid intelligence or working memory, how that's usually tested is you have someone do 30 tests and then you give them a score, like 28 out of 30, correct. And then normal adults have a normal number and we compare it. That's not something we can do in the operating room. And certainly what we can't do is see how someone's going to function in their normal life, right? That we can't really replicate that. And so one of the interesting things about kinetomics is it gives us a path to preserving functions that we, by providing at least you know where the anatomy is, that are very hard to study in an awake patient in the operating room. On the other hand, if you talk about when do I do anesthesia, so I'll give you my general concept, which is generally I go for awake, 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 asleep, right? And I'll tell you where the lines are. Most of the time, now low-grade gliomas are different, younger patients are different, but most people, if you're doing a glioblastoma of someone 50 plus, or anybody who has any kind of neurological deficit, so if they have kind of bad speech, if you put them under GA, even if it's a little bit, it takes them a very long time for that deficit to go away. And now you're forced in the situation where do you just take the tumor out, or do we wait 3 hours? And sometimes it still doesn't come back. And so if I think that they're marginal, it's better to just lightly sedate them and do a good field block. That most people will do fine with that. Now, having said that, on the other hand, once you've made the disconnection, once the brain is disconnected from whatever networks you're saving, and then there's no reason for to keep the patient awake. Like you don't need to remove the temporal tip under awake surgery when it's cut from the rest of the brain. There's just nothing to do with that. So the biggest thing that I learned is that you have to stay disciplined of when do you stop doing your disconnection. So I like to keep the patient awake through the entire disconnection whenever possible, because that's where all the danger is. Having said that, once the disconnection is done, they almost always go straight to sleep because they don't need to. If I'm taking peel tissue, scar tissue off of the middle fossa, it's really painful. There's no awake task there. It's like skull base at that point. It's like we're taking out a met or a meningioma. And so if I'm doing microsurgery, I put them to sleep. The key rules that I have for when I stop, number one, the cut's got to be done, and it's got to be done all the way across in all directions down to where I know where I'm going to stop. So if I'm stopping at the ventricle for this patient, I'm stopping at the middle fossa floor or whatever I'm going to stop, it's got to be done. So you don't just go down the ventricle and you're like, I'm done. That's the first thing that I did when I first started doing disconnection types awake surgery. And what you got to do is make sure you're cut all the way across. And the second thing about it is once you're done, you got to be really careful if you decide, oh, I got to go back and move the margin a little bit. So it's really tempting to see a whole bunch of tumor, like, oh, either the awake matters or it doesn't. And if you see tumor that's deep in the language system, either your option is re-wake them up and do that, or let it go, right? Those are two options. I think that going in there blindly and then you just negated the entire concept of it. But what I will say is the thing that I've learned is that the people who do a sleep awake asleep generally are doing people who are entirely neurologically intact and often are young. So yeah, they wake up pretty fast from anesthesia. But if you're doing some of the cases I showed, who people already have deficits or they're kind of out of it because they have a bunch of swelling, or especially if it's in a deep area like a thalamus type stuff, putting them to sleep is risky. And so I try to keep them awake until I've disconnected everything.
Okay, thank you for your detailed answer. Another question is, how do you localize areas on brain live surgery if patient is put to sleep?
Well, there's two ways you have two options. Okay, so there's a whole literature and experience on motor mapping in asleep patients. I personally do not like that for the following two reasons. Number one, it's really easy for an anesthesiologist to do something to make a motor mapping fail. And then what you end up happening is, like the temperature goes down, or they put a little anesthesia. And then you don't know whether it's this negative because it's negative or this negative because they've screwed up. So I'd rather just have them wait, because then I know for sure that they don't do anesthetize. Second thing is that sleep motor mapping spares the primary motor system. You can preserve the corticospinal tract. It's not clear you can do any of the planning areas. So SMA, frontal ascending. You really need someone doing something to see them stop doing it, or coordination. And all those other things, if you talk about the motor system, you just can't do that asleep. So my view on it is, if you either it's not important and you don't need to keep the patient awake. Or if you need to do mapping, do the best possible mapping you can. And, either it's important or it's not. So I think that when I localize areas, I do it in a couple ways. But what I use the imaging for is to know basically this is where I expect the language to be. And it's pretty close. And so what that does is it makes the cortical mapping go real fast. And I'm confident. I know that if I see a speech arrest and it's right where QuickTone says it's going to be, that it's probably real. And if I'm way away from it, I question it a little more. And so that's the point. Now, if you talk about strategy in cases of reoperation, so I would say you got to put this into two categories. So what kind of reoperation are you doing? It really comes down to who did the operation. Is it someone like me or me, where there's already a huge hole and you've done there's probably you stopped cutting next to function, and versus that this was really just you doing the first real operation, right? The first real operation, if the first case you just say, okay, it's more or less like doing the other operation, and then the wound issues are the only significant difference. But when you are doing oftentimes a reoperation, my thought on it is first is why am I in here doing this, right? Because anytime you reoperate on someone with glioma or any of this kind of stuff, they've been radiated, and it opens them up for problems that can end their life. So, and having said that, I'm pretty aggressive doing reoperations, but especially in the era of laser ablation, focus ultrasound, and other options, it's got to be a big bang for your buck for you to be reopening the craniotomy. And so if you look at it, you say, for small recurrences, I do other things. If it's a big recurrence, if I realize that I'm going to remove a lot of tumor by doing this, and I need to relieve mass effect, I do that. And oftentimes, 70–80% of the time, the recurrence is going to be on the edge of your resection cavity. And so what I do is I often think about it like a little J cut. I find the cavity, because I know if I'm in the cavity that I've disconnected them, and I just basically make a disconnection that shaves into the that starts in the edge and ends in the cavity. Now that isn't always possible, et cetera, but I use the cavity. The hardest part of a disconnection is knowing when you're across, when you really are done. Well, in a cavity, you know when you're done. So I always think in terms of, can I land in a cavity to know when I'm done? Because remember, the hardest part of supratentorial interaxial brain surgery is not stopping bleeding or doing microdissection. It's knowing where you are and what your landmarks are, because there just aren't many. There's still a couple visible landmarks. So all the connectomic stuff is putting landmarks into areas you don't have landmarks, like deep white matter, cortical areas that look like just like their neighbors but aren't, etc.
Okay, thank you again. I will go to Professor Ben for final remarks, and after that, we will end this session.
Yeah, I think, George, Professor Sraza, you can turn on your camera, and Hashan, you can discussion with Mike. Mike, I have another question. So,
welcome, Jorge.
Hello.
If you choose different approach for the glioma, it means different potential risk for different functions. So, so is the patient selection for different functions affected your decision of the approach?
Well, absolutely, right. So if you get to the patient who we did that operation, the anterior occipital video, when I basically noticed that he couldn't read, it turns out he didn't care. He didn't read normally anyway. So that had no consequence. Whereas other people, like if I was alexic, this would be devastating to every aspect of my life, right? It changes a lot of what I do. So yeah, you absolutely have to think about it from a perspective like this. So we used to think there's eloquent areas and non-eloquent, and if you're in the non-eloquent, do whatever you want, go crazy, remove the whole lobe. Well, as always, you can do that. I mean, and I do aggressive resections. You can look at my book and talks and that sort of stuff. But what you have to look at in these particular circumstances, we always have to start with the idea that absolutely none of us would volunteer to have part of our brain removed for non-therapeutic purposes, for recreation. because you rather have as much of your capacity as possible. So when we make that decision that we're going to cut into somebody's brain for some reason, what we have to start to go back to is, where's the least bad path to do that? Given all of the context, who is this person? What are they willing to accept? What is the disease we're treating? And here's another one. If there's a cancer growing into a network, you might not save it by leaving cancer growing into that network, right? So what I used to tell my residents is that the only thing worse than having a glioblastoma in your motor cortex and being paralyzed from it is still having the tumor there and still being paralyzed. Like, at least get the tumor out, right? Now, so sometimes leaving tumor is the right answer, but if you end up leaving tumor and the network disappears in 3 weeks, did you really do anything, right? And so you have to take all this into consideration. Now, when you start talking about molecular markers and other things that predict aggressiveness, it's going to get more complex. So what you say is, every single one of these things, first thing you say, if you can avoid it, you should. Seems to be a good idea. If you can't, or you're picking between two bad options, then yeah, you got to use all the facts to think what's the least bad option. You know, if you're in the lateral parietal lobe, you're picking the least bad option.
Okay, thank you.
Okay, another question? Okay, we think we come to the end. Thank you everyone for joining us today, and we're looking forward to seeing you next week, next Friday.
Yep, next week we'll talk about rewiring the brain with magnets. So it'll be a new topic.
Okay, part
Great.
four. Thank you, Michael, and thanks, Ben, and thanks
Okay,
everyone else.
thank you, Michael.
But thanks,
Tonight, there around 500 audience
Great.
watched your
Great.
presentation.
500
Thank you.
neurosurgeons.
Mhm.
Great. Okay, everyone. Thank you.
Okay, bye-bye.
Bye.
Thank
See you later.